morning, good afternoon, and good evening. Right, so it's a great pleasure to see all of us here together to learn something about the GI abdominal treatment planning all together. Right, again, my name is Chunhao. I'm from Duke University in North Carolina. And today, in this presentation, our goal is to go over some, just like any other sites you have been through, we cover 5 aspects of GI abdominal planning, including a patient assessment, simulation, planning, communication, and possible deviations. Okay, so we're going to start with a patient assessment. So our first step to review the physician intent and the prescription and to understand the clinical background before the simulation. So for GI abdomen, so of course there are multiple sites, but today we're going to mainly focus on 3 main sites: liver, pancreas, and esophagus. And of course, for specific points, we may cover other sites such as peritoneum, knee, node, and some like upper pelvis cases as well. All right, so it's kind of important to understand the treatment location for GI because there could be so many variations about the location of the treatment. That matters to us about how to do the best simulation and how to develop the best treatment strategy. So for liver, what we care is the segment, right? From anatomy, we learned that liver has 8 segments. So depending on the disease, we may have to emphasize a different respiratory motion management strategy and the planning strategy. For pancreas, we want to understand the head, body, and tail. And for esophagus, we need to understand the superior and inferior range of the treatment. So here I'm showing you some pictures, right? Again, so for liver segment, based on this picture, we can see depending on the location on the patient left, right, wise, and superior inferior wise, the respiratory motion of the liver could be very different. So that's something we definitely need to consider upfront. All right. This is an example of the pancreas. So pancreas, we need to differentiate the head, body, and tail regions depending on their different involvement to the other like GI luminal structures as well as blood vessel. So for the esophagus, usually we divide it into 4 different regions on the superior inferior range, including the superior head and neck and lymphanodal region, upper 1/3 esophagus where heart is not in the field, mid 1/3 of the esophagus where heart is starting to blocking esophagus from the AP view, and the lower 1/3 of esophagus. And the very bottom, we're going to have a GE junction, which is the connection of the esophagus to the stomach, which is not shown in this picture. All right. So another second thing we really care is the contrast use. Contrast uses are very often for our GI case because we need to distinguish specific bowel structures from the target. So first, we need to check if the appropriate contrast is prescribed. And again, we need to emphasize that the contrast use is very often, so overriding the contrast during our GI treatment planning is always a top concern here. So for esophagus swallow, we expect the contrast to focus on esophagus and the stomach. And for small bowel contrast, usually we find them in the stomach, small bowel, and sometimes in the large bowel. For IV contrast, of course, the contrast will mainly found in the blood vessels and heart. So sometimes we use a dynamic contrast protocol, which we also call the trigger scan. In trigger scan, we want to visualize tumor or the GI luminal structures with different contrast dynamic phases per timing. So usually we inject the contrast and based on the fixed protocol, like how long from the injection of the contrast, we're going to acquire multiple scans. Of course, based on the contrast dynamics, they're going to show different image contrast. And by comparing different images, we should be able to provide a better visualization of the target. So if this kind of scan is prescribed, we want to make sure this trigger scan protocol is prepared at the simulator because this is something special. You need to program the simulator together with your power injector. So you want to make sure your scanner is capable of doing that. The third thing is a bowel feeling. We understand that the max dose to the luminal OARs is the priority in our GI treatment planning. So we often adopt some strategies to manage the bowel feeling during the treatment. The common way is the NPO, which is shortened for nothing by mouth, right? This is to empty the stomach and the small bowel before the scan and before the treatment, hoping the luminal structures can be a little bit away from the intended target region. So it is important to identify the NPO time. Usually in our clinic, we do NPO 2 hours prior to scan and prior to treatment. Also, we check the special instructions from the physician regarding the bowel feeding. For example, for pancreas treatment, our standard procedure is to give a patient a 12 ounce of water 30 minutes prior to scan and 30 minutes prior to treatment. So this is to give some time to have the water into the duodenum at the time of the scan, so it will show a bulged appearance with a better differentiation from the pancreas head. Okay. All right, the second part is to identify special considerations for radiotherapy in the patient medical record. So for this section, this is our GI site is the same as other treatment set you have been through. For example, pacemakers, implanted cardiac devices. And for GI, sometimes we see other electronic devices such as hepatic pump, right, which is relevant to the patient GI specific functions. And of course, we need to identify any implanted markers and any potential hardware. So this is an example of a treatment patient with a hepatic pump on the patient left abdominal wall. So to spare this kind of electronic device, which we usually call them non-critical, because the patient's life is not does not depend on the function of this device. So for this one, the dose sparing to this device, we should follow the vendor specification, which is always the first thing we want to check if this is available. Otherwise, we have to follow the institutional guideline, right? So as a reference, in our clinic, the dose limit for this such a hepatic pump is 10 gray max. On the right side, you see a picture of a stent, right? Stent is, of course, usually with a titanium mesh or sometimes could be carbon fiber. If you see the enhanced contrast, that's a great potential landmark for the onboard IGRT image guidance based on the image evaluation. All right. Of course, we need to identify any prior radiation and identify if there's a potential overlap. And then we need to request the outside record whenever possible. So if there's no overlap, probably the paper record are going to be sufficient. But if there's any potential lap, we definitely want to request the prior DICOM record, including the scan and the dose distribution. Okay, now let's move on to the simulation. All right, so for the patient setup, right, we want to ensure the setup positioning, orientation, and immobilization is appropriate for our GI site per clinical standard procedures, right? The one keyword here is called the reproducibility. All right, so we want to make sure whatever technology we use for SIM can be done on board as well. So for the GI side, a very common device is the vacuum body bag to immobilize the body. So this is an example of the blue vacuum body bag called Body Fix. It's manufactured by Electa. So the body bag provides a lateral body support. So the whole body gonna be encompassed by this device, providing a very reproducible position in this picture, which is head first supine. And the body fix, this kind of body bag can be indexed on couch, which means the relative position of the body bag and couch will be fixed. So you will have a very reproducible daily couch positions. So in our clinic, mainly we use it for SBRT treatment. In addition, on the right side, you can see the body fix also provides some support to the arm when we have an arms up position. And of course, clearance is a concern because usually when we are treating abdominal site, the arm will not be scanned. So you want to make sure that during the simulation, the arm will be clear from the scanner. So alternatively, we have another kind of vacuum body bag. which is not indexed on the couch, right? That means the body bag, you just put it on the couch and then daily position, especially longitudinal position, you're probably going to see a little bit more variation than the other one. So usually for this kind of body bag is more affordable. So, and in our clinic, we usually use it for regular fractionation treatment because considering the patient cost. And for this kind of body bag, usually you can use it together with other devices such as wing board to provide arm support. And of course, if the if the patient is not that tall and the treatment site is a little bit inferior, you may use other devices to immobilize the patient leg. So here for the GI side, we understand that respiratory motion is something we consider. So for the first kind of a body bag, we can use it together with a technology called abdominal compression to reduce the respiratory motion. So in these two pictures, you can see how it works. And so abdominal compression, it has a fixture attached to the couch, and its position will be reproduced on a daily basis. So there will be a compressor board on the patient belly, right, on the right side. It could have a different sizes based on the patient body size. And to adjust the compression force, there's a screw on the top, right? So during the simulation, you can adjust the position of that screw to adjust the pressure on the patient belly, right? So to make sure that compression itself can be reproduced online, so we definitely want to document the compressor board size and the pressure level. And on the right side, we can see we can take a picture to record the numerical number of the screw's position. So make sure the simulation, the treatment, you're using the same value. So while we understand that abdominal compression is to reduce the respiratory motion, we still need to scan the 4D CT with this abdominal compression to evaluate the respiratory motion. And the lesson we learn is that we cannot do breath hold with abdominal compression because most of the patients cannot tolerate that, right? So you are pressing the belly and you want a patient hold the breath. Most of the patients are going to struggle through that. Okay, so here we have some other devices to reduce the respiratory motion, right? One potential technology is the pneumatic pressure belt. It is very similar to the abdominal compression. This time you use a belt to tighten the patient belly, and you can use some gauge to manage the pressure on the patient belly. So on the right side, we have a thermoplastic body mask. All right, so this is comparing to the body bag we just introduced. The thermoplastic body mask can not just provide a support from the lateral side, but also it controls the body position on the patient anterior side. So the motion on the anterior posterior direction can also be minimized. So here, since we talked about a few technologies here, I want to make a short summary about these devices we just seen. So abdominal compression, again, our goal is to use it to reduce the respiratory motion, but there's no guarantee that it will always achieve successful respiratory motion reduction. So its prior study published that it's likely to fail with a larger body mass index, which means when patient body is big, it's gonna likely to fail. Second, for both abdominal compression and the pneumatic belt, right? So when we are using them, we need a detailed patient-specific setup notes to make sure that the setup can be reproduced for the treatment. So for the patient's thermoplastic mask, in our experience, it's very easy for the daily onboard setup because our machine therapists can just grab the patient's mask and set it up very easy. But on the billing wise, it's gonna be additional cost on the patient. So that is something as a physicist we also need to consider. So when we are treating upper esophagus, we can borrow some immobilization devices from the head and neck side. Right? For example, the long mask from the head and neck, which covers the shoulder, is actually a good immobilization device when we're treating the upper esophagus. And in this situation, we definitely have to have arms down, and we want to put arm close to the body torso for the clearance purpose. If there's a concern about the shoulder position, again, we can use the head and neck side devices such as the footboard to make sure shoulders are straight and arms are down straight. All right, so there are so many techniques we have seen. So what is the threshold of motion assessment? In another word, like when we are doing the respiratory motion analysis, what is the criteria for us to choose different devices? So here, I want to say, different institutions definitely have a different guidelines. Here, we have some like quick numbers from our institution, right? For liver, if we are seeing more than 1 centimeter respiratory motion of the target region, we're going to try breath hold, right? Otherwise, we can go free breathing or abdominal compression. For pancreas, because of the proximity of the target to the adjacent OA, GI luminal structures, our tolerance is 5 millimeter. Larger than 5 millimeter from the 40 CT, we're gonna go breath hold. Otherwise, we stick with a free breathing or abdominal compression. So when we are treating a lower third esophagus or GE junction, again, we use the 1 centimeter threshold. But when you are treating the upper or mid esophagus, we default it to free breathing because in these cases, the lesion is usually attached to the mediastinum or blood vessels. So the motion is kind of limited and the range is kind of small. So of course, there are some other factors we need to consider, right? So it's very hard to just use a single numerical threshold to deal with all cases. So in our GI practice, a very common situation is that a patient cannot tolerate a breath hold even after the like 4D assessment. This is mainly because of their compromised pulmonary function, or they have a degraded cognitive function, which means they don't understand what we say for the breath hold instruction. So if we cannot do breath hold, right, we have to consider the free breathing or abdominal compression, right? So, but when it happened, we have to keep in mind that the motion range is larger than we expected. Usually in free breathing or our abdominal compressions, we have to consider additional setup margin, right, if the range deviates from our guideline, right? So also, with our new machines, new technologies, we can use some advanced IGRT technologies to allow small setup margin under the free breathing condition. So one technique from Elekta is called active breathing control, ABC. Right, so this is a device where it can control the patient breathing amplitude. Right, so in that sense, it's gonna limit the patient breathing amplitude to limit the magnitude of the respiratory motion. Another technique from Varian is called auto beam hold, which we usually call them trigger KV imaging. So on the left corner, you see a screen capture of the ABC on the trigger imaging at the console. So during the beam arc delivery, this technique can acquire KV images simultaneously at a preset condition. And then you can see landmarks, mainly the fiducial markers and their projected position at the KV angle. If you see the deviated position between the marker and the project position, you can stop the beam. All right, so this is another way to track the breathing amplitude during the arc delivery, even under the free breathing condition. Next thing, right? How do we do breath hold? Right, so there are two types of breath hold: end of exhalation (EOE) and end of inhalation (EOI). So in general, for the GI side, end of exhalation may give us a better separation between the GI luminal structures from the target regions. Right, so a common terminology we do when simulating the patient is to tell patient, take a breath in, blow it all the way out, stop breathing. Right, so the patient is kind of out of breath at this moment. On the other hand, just like the breast side, EOI give us a bigger lung volume and push away the heart. So with a bigger lung volume, it can give us a better lung DVH result, right? For example, when we are treating the liver dome region, the lung DVH is a consideration, right? So the instruction is simple: take a breath in and hold, right? So whether EOE or EOI, a top priority here is to pick up one that patient can cooperate and tolerate, right? So that's the most important thing. And here we want to say the EOI doesn't have to be deep, right? In the breast side, we usually force patient to do a very deep one to achieve the best separation between the heart and the chest wall or breast tissue. But this is not really relevant to us. Again, here the keyword is reproducibility, right? We just want to make sure that patient can tolerate that in a comfortable way. So it doesn't have to be that deep. So for breath hold, we understand that a patient breath hold may have some variability here, right? Every time when you ask patient to do breath hold, the level could not be identical. So if that's something needs to be considered, we can acquire multiple breath hold scans when available to assess the breath hold stability, right? In our clinic, we have many devices to track the breath hold, so we can minimize such a breath hold variability. And in some of our satellite clinic, when they don't have such a technology, we usually acquire 3 breath hold scans during the simulation, right? And they want to make sure the 3 breath hold levels are very close or identical. Okay, then finally, when to use abdominal compression, right? So this is a question, not just by physicists, but a lot of physicians have this concern, like they don't know when to use it, right? So we want to share our 2 cents. We mainly use abdominal compression for liver and pancreas because they are sort of in the middle of the body or at the anterior side of the body. Usually, abdominal compression have a smaller effect on adrenal target or upper esophagus target because when the target is very posterior, when you are compressing the anterior belly, it doesn't really help. And of course, when we're treating esophagus target, remember we are pressing the belly, and the upper esophagus is kind of far away from that, so the respiratory motion over there is not really relevant to minimize the motion in the belly. And again, when we are using abdominal compression, we still have to acquire a 4D CT to evaluate the respiratory motion, right? So if in the motion assessment, right, we determine that breath hold is needed, and we cannot do breath hold with abdominal compression itself, we can always take off the abdominal compression to do the breath hold scan, right? Again, we never do the breath hold with abdominal compression altogether. All right, another question is about face gating. So when we do the face gating, this is actually very similar to the lung side, right? So when they're face gating, one condition is the patient need to have a very regular breathing pattern, right? During the simulation, one thing we check the respiratory motion pattern as well as their consistent breathing cycle time shown from your simulation software. Right, so we always have to balance the duty cycle, which means the beam on time versus the motion range. Right, in GI, we usually use a 30 to 60 or 30 to 70 near valley phases. All right, this is commonly adopted because we believe this is a very good balance between the duty cycle and the motion range. So a lot of times this motion range will be assessed at the simulator computer. But during the treatment planning, we also have to double check the motion range of the selected phases once determined in our TPS. Okay, now let's move on to the image quality side, right? So when we review the image quality, right, we need to identify the CT scan artifact and override HU if needed. And we want to make sure the scan range covers the target OERs with sufficient distance to account for the scatter for accurate dose calculation. And we want to make sure the scan field of view encompasses the entire patient surface. So here I have some examples. right? So in this, for this patient, we identified the patient have some metal implant in the sacrum. So if we know this information as a simulation, we have to use the metal artifact reduction scan whenever possible. Yeah. So when evaluating artifacts during the metal implant, so we want to make sure we are using a wide HU window. Mainly it's the bone window to evaluate the true extent of the metal itself and the artifact. And we usually override the HU to water or tissue when necessary. In this example, you see there's a black region between the sacrum bone, and the posterior metal implant. So we definitely, for that region, it's supposed to be muscle, right? So we can override the HU to water or muscle. All right. So in this example, the patient was scanned with abdominal compression, right? This is the patient shown in the picture before, right? So an abdominal compression, from this picture, you see they have additional fixture extended outside of the couch. So this is additional consideration for the beam clearance. We definitely want to make sure this is being captured by the scan. However, the scan field of view setup was too small. So here you can see a teeny tiny cut of the compressor board from the CT scan. So in this case, right, so we understand that we are using a standard, but the compressor fixture, so we know the physical dimension of that. So we actually accept this scan. We just make sure that the therapist can check the clearance on machine before the beam on, before treating the patient. And whenever possible, use the large field of view reconstruction on the CT, if your scanner has such a capability to retrospectively reconstruct a scan. Right. Next part is the variable anatomy. Right. So we want to identify the variable internal anatomy, and we notify physician to see if a rescan is needed. Otherwise, we can proceed with the current patient anatomy and consider adaptive strategy later on. Also, we identify the variable external anatomy, such as shoulders, colostomy, and arm position. And if that happens, we need to consider special beam design and evaluate the beam design impact on the dosimetric outcome. So here is an example of an internal anatomy variation. Right? So on the left side, so we have patient, we are treating a pancreas target, and there's a stent over there, which is supposed to be a very good landmark for the IGRD purpose. On the right side is our day one onboard simulation cone beam CT image. So we noticed that actually, while we are aligning the aorta and the other OERs, such as the stomach outlined by the yellow contour over there, the stent seems to be off, right? So it's pushed very posteriorly, probably due to the variation of the bowel feeling, and potentially, very likely, is to be the weight loss. So this happened on day one and after such evaluation. So we evaluated the patient weight loss together with a GI oncologist, and we decide to resimulate the patient. So this is an example of external anatomy variation. So this is a liver patient, a 90-year-old, and the patient had a problem with the left arm. So the patient wasn't able to bring the arm up. Right? So the patient was scanned with our arm down. In this case, we are treating the liver nodal region. The target is kind of in the middle of the body. So for the liver sparing purpose, we are shooting the radiation from the left side. But we have a left patient arm down. So when that happened, of course, we need to contour the arm and use the beam avoidance to pause the radiation when the arc is going through the arm. And of course, we have to consider the daily variation of the arm position, and we need to add additional margin to the left arm avoidance structure to account for its position uncertainty. All right, the next thing is to identify the contrast and objects and present during simulation, but will be absent at treatment. And for for these two situations, usually it needs dense HU override, and we have to determine the HU override if they are appropriate. So here I'm showing an example of a pancreas SBRT simulated with a small bowel contrast and IV contrast with a dynamic scan protocol. So when we are evaluating the contrast, again, we need to use a wide HU window to show the true extent of the HU enhancement. If you use a narrow one, we may see a lot of a bright region, which may not be the result of the contrast. So when the HU enhancement is above the threshold, we need to override to water or tissue. So here I'm showing you two regions, right? So for the non-enhanced bowel, right? So it was 22 HU measured. And for the enhanced bowel region, it was 146. And our institutional guideline for the enhancement is 100 HU. So we're going to override the enhancement in the bowel. And in the kidney canal, you see there are some IV contrast after the dynamic IV contrast scan protocol. So that actually is pretty high. And of course, we are going to override it to water. So this is another example of excessive tissue, right, from the external anatomy. So this is a lady with a renal cell carcinoma treating the right kidney. So we can see there's some excessive breast tissue in the field of a superior target region, which is shown in red, right? So also, we are able to identify it on the simulation picture. You see the excessive breast tissue from the picture as well. So we definitely don't want to shoot the breast region because they will following a Lara principle. We think we can avoid that. So instead of doing the beam avoidance thing, we communicate with our therapist and we decide to reposition the patient right breast out of field with some tapes. So we can exclude this breast section from the body contour to planning just to either that this breast tissue won't show up for the daily treatment. So on the right side, you also see our home beam CT pictures. So after the therapist effort, we will successfully put the breast out of the field. So we can just start the treatment as we plan. All right. Again, we have to check the image quality regarding the implant electronic devices. And if any for identified devices, we have to follow the appropriate management from the TG 203 from the AEPM as well as your own institutional guidelines. All right, for image transfer, we want to review the image transfer selection of a correct image set in the treatment planning system. Right, so it's pretty common for our GI side to simulate a patient with different respiratory management at the same time, right? For example, right, we started with abdominal compression and we acquired a 4D CT. And after that, we decided to go breath hold. So in this situation, we scanned the breath hold CT and we scanned one with abdominal compression with free breathing, abdominal compression with free breathing condition. So we definitely need to label the image set correctly and communicate with a planner and physician to clarify which set will be used for planning. Okay, regarding motion management, right? Actually, we talked this during the simulation devices. So there's nothing for us to add more here. For the GI side, I want to say this is motion management thing is a part of the simulation condition thing. It definitely needs to be considered prior to the simulation. All right, and for the 4D scan accuracy, all right, so just like the other sites such as lung, we have to review the MIP average and all phases to identify the artifacts and compare them to individual phases side by side to see if there's any motion-related artifact. Right, so for this comparison, as well as the MIP and average phases, they can be generated as simulation console or using your TPS. All right, so actually in our institution, we are generating the MIP and average at the simulation console, but we review the image artifact at the simulator computer as well as our TPS. Right. So if we are going to decide to use the face gating, right, make sure we generate the MIP and average volumes using the selected faces instead of all faces, right? This is a common mistake that we found in our clinic. Okay, so now we're gonna come to milestone here, make a short stop. And here's our Zoom pool number 1, right? Which option below is not an appropriate motion management strategy for the GI abdominal site radiotherapy, right? 1, right? Adopt free breathing to treat a target within 3 millimeters superior inferior motion. 2, try end of exhalation breath hold to reduce target motion. 3, combine abdominal compression and breath hold strategies to further minimize the target motion. 4, face gating if patient has a very consistent breathing pattern.
Sorry, I was answering questions, so I'm launching the poll right now. Okay, everyone, you should see the question on your screen with the ability to answer. So I'll give it a minute or two. We're still having people answer, so we'll just give it a few more minutes. Maybe 1 minute. Okay, the answers are slowing down, so I will end the poll and share the results. Okay, can you see those, Chunhao?
Should I click stop sharing?
No, you can just talk about the results and then.
Oh, I see. Right. So the answer for us here, it should be number 3, right? Again, we cannot combine the abdominal compression and breath hold because they're just too painful for most of the patient.
So I'll stop.
Yeah. All right. Thanks everybody for the participation for the poll. So now let's move on to the treatment planning.
So I'm going to pause just here. We have one question in the chat right now that maybe we can answer.
Sure.
So the question is, what if part of the PTV had air, making it difficult for coverage? Should I override this?
That's a great question. So we were just to talk about the simulation part. So I think we're gonna see something in the treatment planning section, right? So probably this question is a bit early considering the progress of our presentation. But in general, I want to say a short answer is it is what it is, right? If the PTV goes to air, this is because you're considering the possible motion, right? The target will be there. So this is actually a very tricky question. In our institution, we don't override the additional air to tissue, right? But of course, every institutions are doing things differently. I know some people are doing that. There are pros and cons of that. And if I recall correctly, there are some J's, research paper talking about the pro and cons of each technology. So if interested, we can just, connect offline and to share the publications.
Thanks.
All right. So let's now move on to the treatment planning. All right. So for our first part is to evaluate the image registration. Right. For our GI side, image registration can be very challenging. I want to say it can be very challenging. So we have to identify list of a priority because this is not like a brain. We can have a perfect registration, right? Due to the body habitus change and anatomy variation, very likely due to the progress of the disease, it is very hard to achieve a very good registration. So our registration priority recommendation is first, we need to focus on the current or prior target region, right? Second, we want to see if we have any proximate implant landmarks, implant markers such as fiducial clips can be used as reference. So as the implant markers, they're supposed to be more stable and they have more better image contrast. So they should be a very good reference for us. Right. If we don't have any implant markers, we want to see if there's any proximate blood vessels, such as portal vein or submesenteric artery, available, for us to guide us for the registration. So then we can look at overall soft tissue, such as the whole kidney or the whole liver. All right, so if other than all these conditions, of course, we can look at the patient's bony anatomy, making sure because bone itself provides a very good visual contrast for us. So again, we want to say the registration won't be perfect. You need to consider the clinical impact of uncertainties for the registration. Okay, for our GI side, we are actually using the MR imaging from radiology very often to help us identify the target region on our simulation CT. So MRCT registration is pretty common. Again, on the right side, I put the recommended registration priorities here. And it's always a good idea to discuss the registration with additional physicists and physician whenever possible, right? To get like a second eye to verify that, because again, it's just very hard to make it perfect. Okay, so for the contouring, regarding the respiratory motion management, right, we need to identify the ITV, internal target volume, which accounts for the motion, a variation of the target volume due to motion. So for the ITV accuracy, we need to review the accuracy of derived ITV compared to the tumor motion during the individual 4D phases. So in our treatment planning system, so we usually turn on the ITV contour, and over here we play with the movie, which we show the individual faces like a short movie, make sure that like the visual effect of the target region remains in the ITV contour. Right, for the target and OER accuracy, so we have to review the accuracy, completeness, and the resolution of all structures that are used for dose optimization and quality evaluation. So it is very hard to make a firm guideline, but a good idea is to conduct FME analysis, a failure mode effective analysis according to the AAPM guideline. So here I can show the top 3 issues of target OER accuracy in our institution. The most common problem is the incomplete contrast override. Second is the GI luminal structures are missing at certain axial slices. Number 3, right, the PTV high or the boost volume extrude outside of a PTV low, which is the primary volume. So here there is the visual example. On the left side, right, we have the cyan color, which is the PTV primary volume, and the red is the PTV boost volume. It's treating the lower esophagus together with the GE junction. So because of the stray pixel, after the stray pixel in the CTV, after the CTV to PTV expansion, you can see the right contour, the boost volume is a small portion is outside of the primary volume. So this is the issue we have to fix, because usually the boost volume should be within the primary volume. So on the right side, it's showing the missing GI luminal contour. So again, we are treating like a big retroperitoneal target region here. So the orange contour here is the stomach, right? And the green contour here is supposed to be the small bowel. So while we contour the small bowel on the patient's right side, we actually miss the luminal structure on the patient's left side, right? So this is something, we need to identify and fix it. Okay, for the contour quality, we have to identify the missing contour issues, such as missing interpolation, stray pixels, incompleteness, and mislabeling. So this can be a very time-consuming task, just because there were so many things, so many contours, and so big volume for the GI side. So it's a very good idea to implement some automated technologies here to check such kind of common contour issues, right? So we can check this via the scripting function within the TPS itself, or we can check it using some third-party software solutions. Here, I'm showing an example of script system, clear check reporting system based on our Varian Eclipse treatment planning system. So of course, you have to predefine a template here. Here at our clinic, here's what we define: stray voxel pixel volumes less than half cc, right? Stray holes volumes over 0.1 cc. slice gaps, and the laterality, right? That means left was labeled as a right, right was labeled as a left. So we can automate this check with a lot of markers, and this give a very straightforward check of a green check or red cross. Okay, for contour margins, as a physicist, we also need to review the PTV and OER margins to ensure they are appropriate. So the keyword here is to have to follow the physician's order or per protocol at your institution. So develop your, if you are thinking that you don't have a good protocol at your institution, a good way to start developing a protocol to use the RTOG and astral census guidelines when available. Okay, for external contour and support structures, confirm all relevant anatomies, including the body. And when to confirm all objects are attenuated in the beam are included in the body contour. And we have to determine if any structures are blocking the beam during the planning. So this is an example of using abdominal compression of treating a liver region. So here, the red contour here shows the PTV is very inferior target region. So when we are using the abdominal compression, the compression fixture this time is blocking the beam because the compressor itself, you see, is a kind of a pretty high HU comparing to the background signal. So this fixture will be there every day during the treatment, and to account for its beam attenuation, we have to include it in the body contour for those calculations. For density overrides, right, we confirm density overrides as needed, such as high Z material, contrast image artifacts, which we already covered in the prior slide. Okay, now it's my favorite part, beam setting, right? So for the treatment technique, we have to assess the appropriateness of treatment technique, 3D, MRT, VMAT, SBRT, RSS, etc. So for the GI abdominal side, the VMAT is the dominant delivery technique for modulated plans because of their high efficiency and high dose conformity. However, sometimes the static beam MRT can be adopted when non-coplanar beam angles are required. In other words, if we have to use a couch kick, right, the arc delivery will be very limited because of clearance. Then static beam will be an alternative strategy here. 3D static beams can minimize the motion access uncertainty when frequent beam on and off is needed, for example, face gating. So in our clinic, if the patient has to use the face gating, we start with a 3D static beam as a good start, right? If we're struggling of a dosimetric outcome, we may switch to the static beam MRT. A 3D beam should be our should be a prioritized consideration for the face gating. All right, for the beam design, we will need to verify the number of arcs or beams appropriate and verify the angles or trajectories are favorable for the target coverage and OER sparing. Right here, I want to introduce 3 golden rules about the beam setting for our GI side. Right, the first rule, right, so we call the secant measurement for beam arrangement. Right, so in our mind, we imagine that we're going to draw a secant passing through the center of the target to divide the body into 2 sections. Right, the goal is to identify the region mimicking a 180-degree arc, or called half arc. And then we want to see on this side of the secant, when beam going through this side of the body, the entrance depth of the radiation has been minimized. In another word, we want to minimize the entrance radiation to the tissue prior to reaching to the target. All right, so this is an example of treating the liver target on the right side. So if we want to divide the body into 2 parts, right? So we can draw a right line like this way. Then on the right side of this right line, you can tell it's like half of the ellipsis shape, right? So then if we are delivering a half arc radiation, right, the body entrance depth is considered to be minimized in comparison to the other side of the body, right? So on the right side is another example, right? So this time we are treating the posterior liver target region, right? Shown as red here. So if we are following our secant measure thing, so this we're gonna draw secant horizontally, which means it's very similar to the spine treatment. We are shooting the radiation mainly from the posterior side of the body. And based on that, it's just a good start. We can always adjust the angular range a little bit in consideration of other OERs. Right, for this particular patient, we start with like 270° to 90° posterior arc radiation. And this patient actually had a prior long SBRT on the left side. So we rotate the whole arc range a little bit towards the right side. So we end up with 4 partial arcs, 2 on the LPO side, 2 on the RPO side. Right. The second rule is that we are going to evaluate the target OAR geometry at the different axial slices. Right. In other words, we imagine ourselves as a tomo machine, and we arrange beam differently on the ISI range because there's no rule saying that we need to have one beam covering the entire superior inferior range. So let's look at a whole esophagus evaluation case to understand what we are talking about over here. So when we are treating the upper 1/3 esophagus, right, the heart is out of field. Right, so our strategy here is to shoot radiation from the RPO region and LPO region and AP region in order to spare the RAO and the RAO and the LAO region in the consideration of lung, both V20 gray and V5 gray. So we're gonna have so over here we're gonna have like Mercedes shape, 3-beam bouquet to achieve this consideration. And then we're going to move on to the mid esophagus. So this time we have a heart in the way, right? So for the heart sparing, meaning the V20 gray and the mean dose, it's not a good idea to have the anterior beam bouquet anymore, right? So while we are keeping the RPO and LPO radiation, we are going to extend our avoidance sector from the LAO section all the way to the RAO section, including the AP, right, to avoid the heart as well. And when we are moving down to the lower esophagus, here, we don't have a lung in the field. We don't have a heart in the field. So we're probably going to use the full rotation to achieve a very uniform dose within the PTV because we want to minimize the hotspot to the stomach or bowel structures that are overlapping with the target. So on a sagittal view, right, we don't have to totally shut the lung or heart from the full rotation field. So we can have a full rotation starts at the bottom 1/4 of the heart, right, to enable a full rotation, which is about the liver dome region. So taking all together, right, we can use VMAT technique with avoidance sector to achieve our intended beam design. So this is actually the template beam in our clinic for treating the whole esophagus. We have 2 beams treating the upper esophagus, have 2 avoidance sectors, and 2 beams covering the mid esophagus using one long avoidance sector, and again, 2 beams with a full rotation treating the very bottom lower esophagus. Rule number 3, we want to maximize the modulation during the modulated delivery. So our goal is supposed to reduce the MLC leaf travel, right? So we're gonna have introduce idea called the split arc view. We don't need to cover the target at all beam angles, which means you can just have each beam cover partially of the target, a part of the target. And when combining all beams together, right, the target will be fully covered. Right. In terms of the modulation, right? So if you are using the LINAC, variant LINAC, the jaw itself will define, X jaw itself will define the leaf travel distance, right? So the magic number here is called 14.5 centimeter, right? If you keep the X1 to X2 position less than 14.5 centimeter, you will have a full modulation, which means your MLC leaf can travel from X1 side to X2 side with the capability of fully blocking the field. Again, this number only applies to the variant machine, variant true beam machine based on their design. Different machines have a different design. And we understand some of the electron machine, they don't have an extra. And some of the variant machine like Olsen or Ethos, they are jawless. They don't have a jaw at all. All right, but idea here is the same. We want to reduce the modulation, enhance the modulation by reducing leaf travel. So this is an example we call the dual arc split, right? So you can see this is two arcs treating the lower esophagus, right? So if we have one beam at the collimator 5 degree, the extra will be too wide, right? So we're going to divide into two beams, one covering the left side in the beam side view, one covering on the right side of beam side view. For each beam, we limited the extra opening or the leaf travel distance less than the 14.5 centimeter, but putting them together, right, the target will be fully covered, but we are able to maximize the modulation in each of them. Right, so this is another example of a whole stomach treatment. So we use two arcs, right? Again, left split and the right split. So putting them together, we are able to achieve a very uniform dose distribution within the targets. For such a big target, see our 3D maximum is only 107.4%, which is actually very uniform. And you see very minimum of 105%. All right, sometimes the target is too big, right? If you use two arcs to split the view, probably you're going to still struggle with a dose heterogeneity inside the target. And then we have this 4-box technique, right? In the beam side view, this is up, bottom, left, and right. Each beam will cover a part of the target, but putting them all together, the target will be fully covered. Right, so a variant of the 4-box is to arrange the beams on the superior inferior range direction only with a multiple narrow beams to maximize the modulation. Of course, if you can, you don't have to stick with 4 here. You can add 5. You can add it to 5 beams or even 6 beams if you're treating a very long target, right? This is an example I borrowed from the pelvis treatment. This is like an anus patient, a rectal cancer. So due to the involvement of inguinal nodes here and here, the treatment, the field on the in-plane dimension will be very big if I put a collimator 5 degree. So our strategy here is just to put all collimator near 90 degree and have a 4-box covering from superior to the inferior. Again, when adding them all beam together, the target will be fully covered. All right. So now for the beam deliverability, when we have a very complex beam design, we have to confirm the beam deliverability by verifying that there will be no collision between the machine, couch, patient, or immobilization devices. So while we can check it by our manual measurement from the CT, we currently have many software solutions to automate this process. Right, so this is the the script-based clear check software in our Eclipse system. We can automatically check the beam collision with some color scheme. The green color means the beam will clear, safe to proceed. So beam robustness, we want to confirm the robustness of the beam arrangement in terms of avoid angles and minimize the impact by the poor setup reproducibility, such as arm down, and we want to avoid angles that may be affected by the variable internal anatomy. Okay, now let's move on to our second zoom pole. Right, which factors should be considered in arc beam arrangement? Number 1, target volume location within the body. Number 2, OER dose volume sparing. Number 3, patient setup and its reproducibility. Number 4, all of them above.
Okay, you should see the zoom poll getting close to 50%. Okay, I'm going to go ahead and end the poll. and I'll share the results.
All right. All right. So the answer is 4, all of them. Right. So actually we, in our beam design part, we have discussed all 3 points there. So when we consider them, all of them should be considered. Okay. Thank you, Lindsey.
And then we can take a moment to ask one question that we got in the chat. If you can just go ahead and explain the first of the 3 golden rules a little bit more.
Sure. Yeah. Yes. So, our goal here is to draw a line. Let's say draw a straight line, right? Imagine we are covering imagine we are going to cover the target by a partial arc, 180-degree arc, right? So we want to draw a line passing through the center of the target and divide the body into 2 parts, right? We're going to shoot the radiation from only one side, not the other side. Right, so we are gonna play with the placement of this line, mainly the angle here, that we can minimize the tissue entrance radiation. Right, so that's the radiation to the tissue before reaching the target. Right, so in this way we can minimize the radiation to the non-target region. Right, so over here, right, so imagine the target center is here. So we draw a line here. The only thing probably we can play is the angle, right? We can draw a line this way, or this way. All right, and we are gonna shoot the radiation from, again, only one side. So considering all this, probably the best strategy is to draw a line like this way. And we are shooting the radiation from mainly from the RAO side, the right anterior oblique side. Right, so because by doing this way, we have a very shallow entrance to the chest wall comparing to the beam entrance going through the liver. Right, did I make myself clear?
I think so. Seems clear to me.
I just want to ask another about the other picture. The line is horizontal in the other picture. My comment, why it isn't with angle 2. Can you hear me?
Yes, I can hear you.
Yeah, I'm commenting about the other picture in which the red line is horizontal.
I'm sorry, you were cut off a little bit.
Yeah, okay. I'm talking about the right picture when the red line is horizontal. Yeah. Why it's horizontal? It's better to be, in my opinion, it's better to be with angle 2. Yeah.
Oh, I got your point. So that's a very good point. So let me see if I can use annotated here. So we are focusing on liver. Over here, if you just consider that one, horizontal one is the best strategy in my mind. I agree with you. If you just look at the whole body, of course, we may draw a line this way. Right? So I guess this is a line in your mind, right? But if we do this, we do partial arc, we probably get more entrance dose to this part of the liver, right? And since we are prioritizing the liver here, so this is a line I would draw more horizontally, just because I want to spare more liver. And again, this is probably when we are saying this rule, this is just a trick for to consider that. Right? If you put a beam this way, I'm pretty sure you can have a very decent plan. And of course, it really depends on the constraint you are expecting from the physician or guideline, right? So if you have a very tough dose constraint on your liver, I would say loading the radiation, right, by following this red line, probably going to help you with more on the liver dose volume constraint. Clear?
Thank you.
I get it. Thank you.
Okay, I think we're good to go on.
Oh, yeah, let me see if we can, sorry, that annotate, move all of them, clear the annotate. Okay, so we just finished our Zoom pool, right? All right, so let's resume on the beam design part. And now last thing is the beam energy. So we want to confirm beam energy selection is appropriate. right? Usually, if your machine have a 10x or 10 FFF, so these two energies should be more commonly used, just because when we are treating body, we have to consider the beam penetration, right? So a higher energy will be better in terms of a beam penetration. 6x or 6 FFF energy definitely can be useful when we are treating shallow target, right? Less entrance tissue depth to the target, such as some of the liver target. And we do not use the 15x for MRT or VMAT delivery here due to the neutron consideration. And if the patient has some like pacemaker or any other cardiac implant electronic device, according to our TG guideline, you have to use a lower energy, again, for the neutron consideration, right? So for beam design, we have to review the beam side view design for appropriate target coverage and excessive small apertures, right? And screen for MLCs that do not conform to target due to over travel limits, right? So here I'm showing an example of rich and parenteral target treatment near the right adrenal, right? So this is a big target, so we are using a full arc rotation. So when we are reviewing the beam side view, right, we notified here at some certain beam side view point, the MLC leaf gaps cannot travel outside the jaw. They are parked inside the jaw aperture. This is mainly because the X jaw is too wide. So we are hitting the MLC limit. They cannot be moved outside of the jaw. So in this case, you can tell the X jaw is about 18 centimeter. It is too wide, right? So to mitigate this issue, right, so best strategy is to, again, adopt our arc view split technique. One beam covering left, one beam covering right, and this issue will be gone due to the MLC travel. Okay. For dose rate, we need to verify the dose rate appropriate. And we usually use high dose rate whenever possible, especially for the SBRT, considering high dose per fraction. For modulation factor, we want to verify the factor is within expected range of the modality and the treatment site. So a simple rule, the overall MU of the plan divided by the prescribed fraction dose in cigarette is a very straightforward indicator of a modulation factor. But this applies to the simple beam design. What if we have a very complex beam design, such as a split arc view, because not every beam is covering the whole target. So we need a more quantitative approach to assess the modulation factor. Here at our clinic, we have developed a script based on this publication from Medical Physics in 2010. So this paper introduced a modulation complexity score that is independent of beam design. So it ranges from 0 to 1, providing a quantitative measurement of the modulation. Again, this is our clinical approach. As a physicist, besides this simple rule of thumb, you can develop our other institutional guidelines in terms of a modulation factor evaluation. Right, for beam modifiers, right, so it's mainly for 3D beam, verify the wedge and other modifiers are used appropriately, and review those lines, hotspot to see wedge angles appropriate. Right, so in our clinic, 45 and 60-degree wedges are commonly used at our institution based on retrospective analysis. So if I'm going to see a plan with a lot of 15-degree wedge, I usually take a second look to see if they're really necessary. Right, the bolus use is most of the time is not really relevant in our GI situations. Okay, moving on to optimization objectives. Right, so for target objectives, we want to verify the target have both upper and lower objectives with a reasonable separation. So the large GI target volumes demand a very homogeneous dose distribution due to their overlap with functional GI luminal structures. So our goal is to minimize the 105%, of course, and control the hotspot. But if we are treating SBRT, right, for ITV, GTV, usually the hotspot is okay to maximize tumor control, and sometimes it's actually get favored by the physician to burn the ITV and GTV when they are center. However, we still need even say we are okay with the hotspot according to TG 101 guideline. So less than 120% of hotspot is recommended. So when we are talking about the maximum dose, so usually we see a very long tail from the DVH, on DVH, and then the treatment planning system reports the maximum dose as an extrapolation of this long tail DVH. Depending on the different algorithm, it may not be very accurate. So a more robust approach here is to report a point max at a dose at 0.03 cc or dose at 0.003 cc, right? So in our clinic, for regular fractional cases, we define a max dose at D 0.03 cc. For SBRT, we define a max as D 0.003 cc. For optimization objective priority, we verify that a priority reflects the physician planning goals, right? And we can adjust the priority and the constraint based on optimization cost when it's available. I understand this is not always available for some treatment planning software. So this is something based on our experience using Eclipse. And for some software, such as RayStation and Pinnacle, this may not be always available, but you can get the gist here and see if you can, adapt your strategy for the other treatment planning software. So in the Eclipse, you can see the optimization cost of each structure showing in this red box, and the optimization cost of each specific structure are based on the size of the circle. So in this case, we are optimizing esophagus VMAT case. All right, so we can see the cost per constraint to identify the unreasonable constraint when we have a stable result, which means the DVH lines are not showing drastic changes. We can also see the cost per structure. The rank of the structure, this cost should ideally reflect the priority of all these OERs in our mind. So for this specific case, we can see we have a very high cost on the target coverage, heart sparing, and the liver sparing. So when I see this, while I understand that the heart sparing is very important, the liver sparing at low dose actually is not a priority in this case. So based on the cost of this constraint, I'm going to lower the priority or adjust the position of this constraint. So I can spend more, I can have the optimizer spending more effort on coverage versus the heart sparing. For missing objectives, we have to investigate the impact of structures not including optimization. So there's no such rule saying that you have to put a constraint on every structure that will be used for DVH evaluation. For example, if you are going to use rings, artificial rings during optimization, you can actually omit a lot of constraints on the OERs that are far away from a target region. But I think it's a good idea to turn on the DVH result during the optimization, even if you don't have a constraint on them to monitor the result, because you don't want the OER result to be far away from your expectation anyway. For conflicting objectives, we have to investigate them if they cannot be achieved by optimizer, right? For example, for esophagus VMAT, we want a PTV 99.8% covered by 45 gray, and one stomach Dmax is less than 4250 Cgray, while they have a 1% overlap. Clearly, they are conflicting, right? So in general, we recommend that we should avoid the conflicting objectives. However, we are okay to allow with it if the isodose and DVH results are not impacted in the final plan. And during the finalization, objective costs are reasonable. Again, in another word, if your final plan is okay, you don't have to go back and fix this problem, because that's the point of optimization, right? You are going to have the optimizer to see conflicting things as long as they can give you satisfactory compromise. However, if the conflict is not achieved by the optimizer, it's recommended that you go back and fix it and see if you can achieve a better dosimetry outcome. right? For gradient tools, you want to confirm the proper use of integrated planning tools for the dose shaping structures to achieve the dose gradient, right? For dose gradient, if you're using the Eclipse optimizer, you have a normal tissue optimizer function, NTO. And for most of us, we have been using artificial rings to control the dose gradient. So here, I'm going to just briefly talk a little bit more into the NTO in Eclipse, normal tissue objectives. So there are 4 parameters, actually 5 parameters here. The priority here is the same as the priority when you put on any other dose volume constraint. The distance to border, right? So it's recommended to use a higher value if you struggle with the coverage, right? So if you have, for example, for esophagus, considering the low density of the lung and the extent of the disease, I may use 0.35 up to 0.5 centimeter for the distance to border. All right, so for the end dose, start dose and the end dose describe the virtual exponential fall off of the dose in the normal tissue. So for the end dose, you can use a high values if you have a low density tissue in the field, such as lung, and you can use a lower value, 40% or lower, if your target region is very homogeneous like water. And here, regarding the start dose and the fall off, here I'm attaching a very brief screen capture of the various technical guide. So we don't have time to read through every of them. So I'm going to keep here. And if you're interested, you can come back and take a look. Okay, now we move on to the final evaluation of dose distribution. All right, first, regarding prescription normalization, we verify the plant prescription normalization appropriate. So when we are normalizing a plant to a reference point, the location of this point should be evaluated. We have to avoid the penumbra region and out of region because the dose calculation in this region is subject to more uncertainties. When we are normalizing modulated plant, the normalization value should be close to 100. Otherwise, the beam deliverability could be impacted, and they may require additional check. Regarding algorithm and dose grid, you verify they are appropriate. A fine dose grid is needed for small target and critical OARs. According to TG101, right, for SBRT, they definitely recommend 2 millimeter or smaller dose grid size. Review target coverage and conformity, including use of a quantitative metric when possible. So here we have, I'm showing 2 tools, automated tools we are using in our clinic to evaluate the target coverage or dosimetric outcomes. So on the left side, this is the clinical goals within the Eclipse system. It can automatically report the preset dosimetric outcomes with the actual value as well as the pass-fail criteria with a color code. On the right side is a clear check report system. So it provides an additional freedom of the programming on the dosimetric evaluation with acceptable range, and also the color scheme of a pass-fail evaluation. And here we want to remind all of us that we should not evaluate the plan solely based on this quantitative metrics report. This report should be used in conjunction with dose distribution evaluation, as no guarantee of a comprehensiveness of this report to every patient. Right, regarding hotspot, we had to review both the magnitude and the location of hotspot and the high dose streaking. So sometimes, again, in SBRT, hotspots are favored, but they should be found near the target center. So a lot of optimizers tend to give you a hotspot near the PTV edge sometimes even in PTV minus CTV or PTV minus ITV. So that means you may need some special tricks to manipulate the position of the hotspot. So here we can use inner ring, the ring inside the target, with a fake simultaneous integrated boost SIB technique to manipulate the hotspot. So this is an example of the liver SBRT dose distribution. We are treating this liver target 18 gray times 3. So over here, you see in here the small red contour here is the ITV contour. So we want to push the hotspot inside the ITV. So when optimizing this plan, we pretend that we are treating the ITV with 105% of the prescription dose. In another word, we want to deliver high dose to the ITV on purpose. So we will want to make sure the planned hotspot will be found definitely in the ITV. So in this case, you can tell the 3D maximum hotspot is near the ITV center. So this is an example of static MRT treating esophagus up to 45 gray. So this is a problematic plan with multiple issues. First, you can see the hotspot is nearly 120%, which is very hot. In addition, instead of centering at the target, it's at the target edge and so close to the lung. So this is definitely not acceptable. All right, so the hotspot should be minimized. And also, not just the target, we are also evaluating a high dose streak outside of the target. And in this case, we identify a 98% dose streaking point outside of PTV, very likely due to the overmodulation from the MRT. So this is a spot we definitely need to minimize such occurrence outside of the target. For dose gradient, we need to review the high, medium, and low dose levels with the expected gradient in mind. So this is an example of another liver SBRT treatment, 10 gray times 5. So this is the overall dose distribution. The very low level is 30%, which is 15 gray. So when we are evaluating the dose gradient, we understand that to maximize the liver sparing, we are expecting a higher dose gradient inside the liver comparing to the dose gradient in the chest wall and the lung region, because the priority of liver sparing is higher. So when we draw a dose profile over here, comparing to the 2 points, 5 centimeter away from the target center, we can see we have on the negative 5 centimeter, which is found inside the liver, the dose is much lower than the 5 centimeter on the other side, which is in the chest wall. Right. So in other words, the dose gradient we are seeing in this case actually meets our expectation that a higher gradient should always be found inside the liver. And this is another example of a erythropoietin plus node treatment with SBRT. So the overall target region is getting 5 gray per fraction, and the boost nodal region is getting 8 gray per fraction. So in the dose distribution, when we draw a line profile, we should be able to see 2 rather flat dose regions, one going to 8 gray, one stays at 5 gray. And the transition region of the PTV 25, 5 gray PTV to 8 gray PTV, which means the subtraction of the 2 regions, which shows in yellow arrow, it should be a rather flat one instead of a rather slope. In other words, the dose fall off from the 8 gray level to the 5 gray should also be sharp on the both end of the PTV nodal region. So we can achieve a rather uniform dose region in this flat region shown by the yellow arrow. For the OAR sparing, we confirm all OARs are spared as much as possible in order of clinical priority. So here we want to emphasize a special case that when an OAR overlap with a target, we want to ensure the low dose coverage to this called dual property region. So this is an example of a pancreas SBRT. Right, the big region is getting 5 gray per fraction, going to 25 gray, and the ITV region is going to get 8 gray per fraction, total 40 gray. So while we are trying to give this boost region to 40 gray, our top priority is for the bowel structure over here. The maximum dose constraint is the 33 gray. Right, so clearly the bowel overlaps with a target with our 40 gray PTV. So our priority is to spare the bowel to make sure we are meeting the constraint of point max 33 gray. However, For the overlapped region, instead of pushing it very hard low dose, we want to make sure that this region is at least covered by 30 gray while keeping the 30 gray max, right? Because this region, while it's in a small bowel, is still considered as a part of the PTV. So on our DVH line, we want to make sure that the DVH line, this PTV 40 gray line, is not going to drop from 25 gray. Instead, we want it to drop starting 30 gray or as high as possible while meeting the constraint with a bowel max point 33 gray. So when evaluating DVH metrics, right, we also revealed both metrics around clinical goals in the context of a national and an institutional normal tissue dosimetry goals. And when we are evaluating the plan sum composite with a prior radiation, we want to make sure they are considered as a part of a plan if there's overlap. And considering the biological dose difference if they have a different prescription regime, EQD2 is a very good metric if we are doing a plan sum from two regular fractionated plans with a different prescription. However, now since we are treating more hypofractionation plans, the plan sum of hypofractionated plans can be very complicated. The most recent guideline or recommendation is published by Astro, like a high-tech series. It's from 2 to 3 years ago. If you're interested, they have more details about how to do the plan sum with hypofractionated plans. Okay, let's come to the last Zoom pool today. Which statement below is not correct regarding dose evaluation? Not correct. 1. Dose fall-off gradient should be evaluated by spatial dose distribution. 2. Automated dose volume reporting is sufficient to capture all OER dose result issues. 3. When evaluating one hotspot, both hotspot magnitude and location should be considered. 4. Beam arrangement adjustment can help with mitigating certain plan objective issues.
Okay, we'll give it a few minutes while people are answering. Okay, it seems like our responses are slowing down. Oh, we have a few more. Okay, I'm gonna end the poll and share.
All right, thank you, Lindsey. So the answer should be 2, right? So automated dose volume reporting is solely based on the dose volume histogram. And we have to say that dose volume histogram itself does not have a spatial information. So we should always evaluate the spatial dose distribution in addition to the dose volume reporting. Okay, so let's move on to the last section, communication. Right, in terms of a communication plan regarding a specific patient treatment, we are confirmed that necessary information is always communicated to therapists to maintain a high quality. Here we have a few examples that need a prompt communication with the therapist. First, we can make requirements for pre-treatment imaging, such as the clearance check. Right. 2, right, if the plan have a multiple centers, ISO centers, sometimes the order matters. We can tell them which one to start first. 3, for unstable anatomy, right? For example, the kidney patient example we shown before that we need to reposition the patient right breast. This kind of unstable anatomy definitely we need to tell therapist to pay extra attention for the reproducible setup. So 4, regions are blocked in the plan. Right, so this is pertinent to the beam block due to the external anatomy, such as left arm down example for the liver case that we discussed in our prior example. 5, isodose lines or high gradients to note. So this is for IGRT consideration. For critical OER sparing, if this is a non-SBRT case, no physician, no physicist will check on a daily basis, so it will rely on the therapist to implement an accurate IGRT. So one good experience we have is we can convert a certain isodose line into a structure, and we can ask a therapist to use this isodose line based structure to match the critical OERs. to prioritize the OER sparing in some tough cases. Regarding incident learning, so the incident learning is the goal of incident learning is to report a planning related to, so we can like accumulate a library and learn from the incidents happened before. So there are three things that we really care about treatment planning. Like when the event was discovered, it was discovered before planning, during planning, or after planning at the time of chart check. Second, what's the impact on the patient? Does it have if the problem was caught after the patient treatment started, what's the dosimetric impact on the patient? That needs some quantitative evaluation. And of course, a detailed description of the event, including the detailed description of the event in its nature and how it was discovered. So in reality, I want to say the most number of reports we see in our incident learning system are a good catch, which means they have no impact on the patient treatment. Right. The goal of incident learning here is not to pinpoint specific people to hold responsibility of each report event. Right. The goal here is to, based on the report events, right, to identify the systematic and the procedure issues for the correction, right, following our TG100 workflow, right, which means we are learning knowledges from prior cases to improve what we do for our future cases. All right, so we already spent more than 90 minutes. So here I'm going to conclude the presentation, and I want to thank you everyone for your patience.